Thank y'all for coming in here on a, Saturday morning and wanting to learn a little bit about menopause, because truthfully being really proactive and educating yourselves is really your best weapon, okay? Y'all also might know I've done a medical segment on Channel 9 the first Sunday of every month, various topics, a lot of women's health, but pretty much everything in general. And I do a talk show on Talk 107.3 FM that the medical segment is sponsored by Mary Bird Perkins, Our Lady of the Lake Cancer Center. And so you can tune in on Saturdays at 3 and Sundays at 11. But I'm always blessed when they ask me to come talk at this event here at Pennington. It's a great thing. And, menopause, there's a lot of misconceptions. There's a lot of questions, and sometimes women are desperate and they do the wrong things because there's a lot of information out there, and it's really sifting through that information so you don't do something that's harmful. But I think the first thing that I thought that we should talk about is it even menopause, right? So first of all, I want to look at the young woman. I have women that come in and they complain of hot flashes, and maybe they're in their 30s, okay? So yes, it's possible premature menopause, and premature menopause is menopause that develops in anyone under the age of 40. So it can be natural or it can be induced. One of the causes may be premature ovarian failure, which means that for some reason your ovaries aren't making enough follicles, or there is some ovarian dysfunction. And most of the time we don't know what's caused that. But there are some causes that we do know of, and some of that is that it can be induced by chemotherapy or radiation therapy. Of course, if somebody has a hysterectomy for a condition like endometriosis, they may have their ovaries taken out because their risk-benefit ratio is, it's more beneficial to take them out in a person who has endometriosis because it's stimulated by the estrogen. And then there's some other autoimmune disorders and things that can stop the ovaries from functioning. Sometimes women will think, well, is it stress? Well, stress itself has not been shown to cause it, but some of the things that people do when they're stressed, like having a poor diet or heavy drinking or smoking, can play a role in early menopause. And so when we look at, well, how many women could this really affect? Well, 1 in 1,000 women between the ages of 15 and 29, and 1 in every 100 women between the ages of 30 to 39 can be affected by premature ovarian failure. And, but what I really see is those women, they come in and they're really just having hot flashes, okay? But they're having regular cycles. So the key is, if you're having dysfunction in your ovaries at an early age, you're going to have some period irregularity. Okay, and so if you're having regular periods but you're having hot flashes, you got to think about other things, and we're going to talk about this as you get older as well. Smoking can cause hot flashes. If you're overweight, it can cause hot flashes. Thyroid dysfunction is really a big one in younger women that can cause hot flashes. Certain medications it can be a side effect of, and of course some of the medications that we use say to treat breast cancer because it knocks out the estrogen, like tamoxifen, and those, they cause hot flashes. Medications to treat endometriosis like depolupron, because we're trying to knock out the estrogen, can cause hot flashes, and some of those things are temporary and sometimes they're permanent, especially with the radiation or chemotherapy. You don't really know, is it going to be permanent or temporary? So, but I think what we really want to spend a lot of time on today is the menopausal age woman. And what is that? So the average age of menopause is 51. The typical range is 48 to 55. And sometimes for 3 to 5 years before your periods actually stop, you can have some fluctuating hormone levels, and so your hormones are kind of doing like this, okay? So that's why I say, by definition, if you are in the right age range and you have been a full year without a period, you are probably menopausal, okay? Now, I might want to make sure you've had your thyroid checked, because that happens commonly in that age group too. But If you come to me and you're 51 and you hadn't had a period in more than a year and you've had a recent thyroid check with your primary care doctor as a routine blood panel, I don't really need to send you and waste your money on an FSH and an estradiol level. I can tell you right now that your estradiol level is going to be under 20 and your FSH level is going to be greater than 40 and you're menopausal. Now, if you come to me and you hadn't had a period for 3 or 4 months or 8 months, I might want to check that level, because if it is abnormal, I know you're perimenopausal. If it's normal, I'm not going to tell you you're crazy. I'm just going to tell you that I probably caught it when it was up here, but it may be back down here if I rechecked it. And so perimenopause is that time where you have fluctuating hormone levels. Okay, menopause, no period or more after a year. And I think that that's important for women to know, because I recently had a woman come in and she was really, really nervous because she had seen her primary care and she had had the hormone levels checked and she hadn't had a period for 4 months. And they told her she was menopausal. Then she had a period. And she then got on the internet and started Googling and saw, oh my gosh, bleeding after menopause, I might have uterine cancer. And she was very nervous. And so I had to tell her, well, they just caught your levels when it was down here. You might start having regular monthly periods, or you might have one and then you might not have one for 8 months. But you're just in that perimenopausal range. It's not abnormal. Now, if you had abnormal bleeding, let's say you're bleeding excessively heavy, which sometimes it can be after like not going for 3 months, then yes, there might be something that you tell me that says we ought to look into it. But she was basically concerned because she had that number and was told she was menopausal and was really concerned because she had the cycle. So I think that, that it gets very confusing. So perimenopause, fluctuating levels. Menopause, no period in a year, shouldn't bleed after that. Then that's an issue. And postmenopausal and menopause basically are the same thing. Most women think postmenopausal means I'm done with it. And, I'm done with it. And as we were talking earlier, that you are in, once you go a full year without a period, your body is in the estrogen deficiency state for the rest of your life, unless you choose hormone replacement therapy and add some back. But basically, you're menopausal and you're having effects on your body and tissues and organs of estrogen deficiency. Now, your symptoms may go away. It doesn't mean that you'll have symptoms for that long, but some recent data is coming out saying that, you may have symptoms. The average looks like 7 to 11 years. You're like, whoa! But think of it too. 30% of women don't even have any symptoms. 70%, they're going to have them. Every woman experiences differently. Some women will have every symptom on there and it is life-wrecking. Some women will have some symptoms and like, it's not too bad. I know I'm there, And so it's really variable. Some might have one symptom that's really bothering them and not everything. And then, during that perimenopausal time, sometimes for 3 to 5 years, you might do that before you actually quit having a period, where your hormone levels are doing like this. Okay? So let's kind of take, and let me mention older women, because I think that's a thing too. So let's say you're that woman who just breezed through menopause. You didn't have a symptom in the world. And then you come into me and you're 70 and you go, man, doc, I don't know what's going on, Like, I didn't have any trouble, but man, now I am having hot flashes. Okay, because that's the biggest symptom that women complain about. But if it occurs later on, you got to think about those other causes, okay? So I usually say, well, we need to look for other things. We need to make sure your thyroid's been checked. That can happen. We need to look at your medication list. We need to rule out, other issues and medical problems that can cause hot flashes. Anxiety can cause hot flashes? And sometimes I'll say that. They go, oh yeah, that's the one probably. I've been on, you know, had all that going on this year. But you look at other causes and don't just assume that you started having hot flashes when you're 70. The other thing is, like we said with the bleeding, I did have one lady come in too, just for her regular checkup. Thank goodness she came for an annual exam. But she says, you know, Doc, my granddaughter moved in with me and I started cycling again. You know, I think that that's something. You know, I've heard that, you know, if a family member moves in with you, or you're like, you know, with somebody else, you'll start having your period again. And I started having my period this year. I'm like, that's wrong. That is so wrong. That is not supposed to happen. Thank goodness you were here for your annual checkup and you're telling me that. But we got to check this out. Because, I mean, it could be something simple like you have a polyp, and usually those are benign things in women, but you could have some precancerous cells, or the worst thing when you have bleeding after menopause is uterine cancer that we got to rule out. So, you bleed after a year of menopause, that's wrong. You need to be telling somebody about it. So, let's look at this next slide, which just kind of goes over all of these symptoms of menopause. And like I said, in the perimenopausal time, you may have those irregular cycles. You know, granted, if you go 8 or 9 months without a period and it's every time you go on a vacation, just stop taking vacations for about a year. I'm going to tell you, because I can't tell you how many people's like, yeah, man, I'm going to tell you, I'm going on a cruise, I'm going to have a period. I'm like getting on an airplane, 5 months later, I'm gonna have a freaking period. And I'm not planning it because I've been 8 or 9 months without a period. So just quit. No, I'm just teasing. But irregular when you're perimenopausal, 1 year without, you shouldn't have them. If you do, it's a problem. But hot flashes, night sweats, those are really at the top of everybody's list when they're having menopause. Mood swings, you know. I usually tell my women if they're having no other symptoms and it's only bothering their husband, don't worry about it. It's only if it bothers you. But sleep problems, that tends to be an issue too. That's an issue just as women age, but you know, we happen to be menopausal too. And so weight gain, every single woman comes in and says, oh my gosh, Doc, I hit menopause and I just cannot lose weight. Well, you can, but you do have to work at it harder. Okay, and we're going to talk a little bit about that too, because one, your metabolism slows down after you're menopausal, and a lot of women will complain of thinning hair and dry skin. If it's before, again, those can also be signs of hypothyroidism, so you want to look at that. They do complain that their breasts start sagging because you do get less fullness in the breasts, and vaginal dryness is a really huge one. And I love this cartoon here. There's so many menopausal cartoons out there, it's crazy, but you know, having 9 lives is cool. But if I have to go through menopause again, forget it, you know? So once we go, it is menopause. Now, what do I do, Doc? Well, the first thing we look at, some women will say, and some of it's because of when the Women's Health Initiative study came out, back in 2002, women kind of freaked out. And said, oh my gosh, I don't need to be on hormone replacement anymore. Now, there's been more information coming out since then, and we'll talk about that. But a lot of women are like, you know, I just want to try doing some things myself, you know, and see how this goes. And certainly, even if you choose a prescription option, it helps to do some of these things. So a big thing is what we eat and drink. So one of the things, hot beverages, caffeine, spicy foods, any kind of alcohol, especially red wines, the tannins. And I have some women, I'll go, you know, Doc, I'm good during the day, but man, at night I'm just having these horrible night sweats. What do you do before you go to bed? Well, have a glass of red wine before I go to bed. Well, how about you quit that and let's see how they get. Oh yeah, forget that. Well, you know, it just depends on what you want to do. But all of those things trigger them. There's a whole lot of other things that you can do too as well, and one of them is weight loss. Cool. So then sometimes women think just because they're not getting a prescription, they're taking something safer. That's not necessarily true, because just remember that when you go reach for an herbal supplement, that it doesn't go through any rigorous FDA screening. It also has side effects, okay? So it can cause blood clotting, blood thinning, you know, same things that we worry about. If it has estrogenic properties, it may have some of those estrogenic effects. You just don't know how much. And there was a study, well, it wasn't really a study. It was like a report that was on 20 years ago, and I always remember this because they looked at a product, and some of them had like 100 times what it said was in it. Some of them had nothing that it said it was in it, you know, some did, because it doesn't go through that regulation. So when they look at some of these things, and the more herbs they put in it, the greater your potential risk, right? So black cohosh has been shown to, it's one of the ones that we do know that it helps, you know, with hot flashes. But you just have to be careful because the product itself is not regulated. So, which is, you know, why too, it's always important if you're having surgery or something, and you should really let your doctor know all the things you're taking, because sometimes people don't let their docs know what over-the-counter stuff they're taking, and those can actually be impactful and cause bleeding issues with surgery and stuff, which is why we ask everybody that, and certain things we ask them to be on. We're gonna like hop over, and let's say you go, no, this is not manageable on my own. I'm really having symptoms and I need something. A lot of times women think that their only option is hormone replacement. And believe me, there's a lot of options within that as well. So which one is the right one for you? Well, that's a thing that you have to talk to your doc about and see. Big thing, one, if you have your uterus, you cannot take estrogen by itself, because it will cause the lining of your uterus to build up and increase your risk for uterine cancer. So they added the progesterone in there. Now, when it first came out, it was only as a cyclic hormone replacement. So you would start having a period again. Most women said, well, forget that. I don't want to be having a period. So then they made regimens, which they call continuous combined hormone replacement, which is a low dose of estrogen and a low dose progesterone to keep your lining thin so that you have less risk for developing uterine cancer. So it keeps that lining from building up. So most people don't do the cyclic anymore. Maybe if somebody's perimenopausal, they'll choose a really low dose birth control pill, you know, if they're 48 and they're having some cycle irregularity and some symptoms, and, you know, they don't have any contraindications to it. They even have pills that are and especially if they still need some contraception during that time, because until they've been a full year without a period, they can't say it's not possible to get pregnant. So low-dose birth control pills, if it's not contraindicated, is a really good option. They have them down as low as 10 micrograms. You know, low dose used to be 35, and then went to 30, and then 20, and then now there is one that is 10. So that's an option in the perimenopause. Once somebody is menopausal, if they choose hormone replacement therapy and they still have their uterus, most are not going to choose cyclic hormone replacement. The majority of products are going to be continuous combined hormone replacement, which means that you have estrogen and progesterone both. They put them in the same pill because when they used to have them in separate pills, women didn't take their progesterone, and then guess what? Then they came in bleeding and had endometrial hyperplasia, which is a thickness of the lining that's a precancerous state going into uterine cancer, right? So they do put them in the same pill. Makes it really easy for everyone. There's two regimens. You can take it orally, or it also continuous combined regimens come in a patch. Now that is different if you're a woman who has your uterus out. You don't need the progesterone. The progesterone is really to reduce your risk for uterine cancer. You just need estrogen replacement, because that's the estrogen deficiency is what's causing all of your symptoms. So you have lots of options. You have pills, and of course now with insurance stuff, you need a generic. You know, your insurance is only going to cover that. So, you know, most people are going to be on a generic oral estrogen replacement tablet if they choose oral. There are multiple brands of gels. So the other option is transdermal we have listed on here. That means you're going to get direct absorption into the bloodstream. It doesn't have that pass through the liver for breakdown. So a patch, you can do mist, very convenient. This little squirt right there, change the dose 1, 2, or 3 depending on your symptoms without changing the product. And then you have gels. They come in pumps. They come in like peel-off ketchup packets. And You know, so that's your transdermal options. Pellets and injections, they are not recommended by the American College of OBGYN, and why is that? With any of the two that I mentioned, you are keeping a consistent, steady state of hormone replacement, right? So with pellets and injections, you get a burst and then a drop. Also, if you develop some bad issue, you are stuck with it. You can't stop it, right? Where you can with the other. So let's say you had an injection. That's a depot, that's gonna be lasting for a while. Also, you're gonna feel great. You're also, when it's high up here, you're gonna be at greater risk of the big side effects of hormone replacement, which is blood clots and strokes, breast cancer, right? So, and then you go down here and then you feel like crap and you desperately want the next shot. So the pellets, I've had some patients sent to me from their breast surgeon, who another physician put in a pellet and said, you know, they've got breast cancer now, can you take these out? And it's like their doctor who put it in said you can, and it's like, no, you can't. And you just have to follow that. I've had women who come in that have had irregular bleeding. You can't take that pellet out. They've had levels in the thousands. Of course, they're going to be at greater risk of blood clots and strokes. You have to follow that till it goes down. You develop breast cancer or you get a blood clot and you were taking a patch or a pill, you just stop it, right? So that's what you want. Bioidentical hormones. Women come in all the time and say, you know, doc, I want something natural. Do you do those bioidentical hormones? Or sometimes my patients who know me go, I know you don't believe in those. And it's not that I don't believe in them, and I bring out this little notice that came from the Louisiana State Board of Medical Examiners that says they have reviewed the opinions of the American College of OBGYN, the American Academy of Clinical Endocrinology, the Endocrine Society, the American Medical Association, the North American Menopausal Society, and the FDA, and has reached the conclusion that routine use of non-FDA approved compounded bioidentical hormone replacement therapy will be regarded by the board as potentially sanctionable unprofessional conduct in violation of Louisiana Medical Practice Act. Well, I'd like to keep practicing. And also, I don't want anything bad to happen to you, but this is what happens is when women are desperate because they want to feel good, they hear something about that, and there's some celebrities who tout it and they go, man, she looks really good. I think I ought to try to get some of that. But one of the things they say, and I always tell my patients, does this even sound real? We're going to swab your cheek, and we're going to send your saliva off, and we're going to make a compounded regimen that's just for you. It's going to be like what your hormones were before. Now, does that even make sense? No. Of course not. You're already menopausal. We don't know what they were before. And even if we did, hormones fluctuate. Even when you're not in menopause, different phases of the cycle, they're different. So one, right there, it doesn't make sense. And two, it's not regulated. So again, I think if you're going to take something, you want to know what your risk and benefits are, right? Your benefits, and the current recommendation for hormone replacement therapy is that you're on the lowest dose for the shortest period of time that relieves your symptoms. Yes, in the past when Women's Health Initiative was started, they thought that they were going to show that it reduced the risk of heart disease, okay? And actually when they looked at and so when it came back, it was like, oh my gosh, the first year of usage, women had a huge increased risk of blood clots and cardiac events, so it stopped the study. But when they really went back and looked at the information, it was really age dependent. Those women who started when they were 50s actually had fewer events. Those women who started when they were 70, because they were all starting in this trial, they had more events. And that's why I was telling some of y'all earlier, I mean, when I started in my residency, I'm telling you, if some woman came in and she was like 80 years old and she wasn't on hormone replacement, we probably talked to her about it, you know? Now we would never do that. And any of my women, when they get to be 70 or even actually 65, and it all just depends on you. You gotta weigh your risk and benefit. Everybody's different. It's kind of like, but some people just get used to taking it for so long. It's kind of like, let's squeak you down. Let's get you on the lowest dose. And then if you stop it and you don't have any symptoms, then great. You're at a point where that thing has shifted, okay? Before, your benefit was much better. You were miserable, but over time those symptoms may go away, right? And then your risk just from aging goes up as you get older. I mean, you get vascular changes that's going to increase your risk for blood clots and strokes. And then if you can come off of something that is a risk factor, then great. We'd like to get you off of it. You know, and some, you know, with, you know, everything trying to so many controls and stuff. If you hit Medicare, I tell my women, I'm going to get a nasty letter that says your patient is on a dangerous drug. You should talk to her about getting it off. And so I'll usually talk to her. I have some if they don't have any other contraindications, and they're like, I've stopped it, doc. I just can't manage. I have hot flashes. They're terrible. It's like, okay, she knows her risk and benefits. She's choosing to be on it. Now, if she had a contraindication, if she'd had a blood clot or a stroke or some event, she's going to get off of it. It doesn't matter. I am not going to give it to her. There are some that will go search it out, and they will go get on something at a bioidentical place. It's terrible. Not that they should do that, but some women will just feel like, I've got to have it. You know, but you always want to make an educated decision. And so really, things change. It's not because if you've been on it since you're 50 that you're not going to stay on it till you're 100 now. You know, you're going to at some point, that's going to shift, and you should get off of it because your benefit is lower, your risk are greater. But some women can't take hormone replacement because they've had breast cancer, or they've had a blood clot or a stroke, or they have some medical history that says it wouldn't be good for them to be on it. They don't have to suffer, okay? There are some alternatives, and a lot of times women don't know this. So the big symptoms, hot flashes, night sweats, mood swings, and sleep issues can be helped with SSRIs, selective serotonin reuptake inhibitors. So frequently in a lower dose than it would be used to treat anxiety or depression. So 10 of Paxil, 10 of Prozac. Normally you would start somebody on if you were treating anxiety or depression probably at 20. A lot of women that will relieve their symptoms. Neurontin, which is used for nerve pain and other issues. Sometimes you can be treated for some other issue and you get a twofer. It helps you with your hot flashes, you know? So especially like when women are saying, yeah, I'm having some anxiety too. Heck, let's try this alternative because, you know, we're treating two things. And then I really want to spend a little bit of time on vaginal therapy, so I'm going to shift back over to the beginning because a lot of women will say, maybe they don't have hot flashes or night sweats, but over time, as I said, you have the effect of less estrogen on your tissues. Okay, so one of the things that happens over time, your vaginal tissues are going to get thin, they're going to get what we call atrophic, then you have pain with intercourse. So, and that becomes an issue, you know, in women's relationships. And then once that gets going, they'll say, and I don't really even care to have intercourse. But if they associate it with pain, it gets this big loop going around going, I don't want pain, I don't want that. And so the first thing is over-the-counter lubricants. Believe me, I did a talk on nothing but pain with intercourse and menopause and vaginal dryness. And I went to get some samples and oh my gosh, the wall of lubricants. So what you want to do is you want to choose a water-based lubricant. If you're just having symptoms with intercourse, that's one of the first things to try. There's a whole lot. Lubricant, Replens, Gyne Moisture, and Astroglide. Who comes up with these names? But anyway, that would be the first choice because you can just use it with intercourse. But sometimes women, the tissues will get so thin that they will feel like they have an infection all the time. And they will feel irritated constantly, so it's not just with intercourse. At that point, or if the over-the-counter lubricants don't work, then the next shift has traditionally been to adding some estrogen replacement down there. Now, it's directly absorbed into the vaginal tissues. It's going to list every side effect as it does if you are like getting estrogen through the IV. But if you don't use more than is recommended, it is vaginally limited, so you don't have to worry as much about side effects. And I've had patients who were, you know, seeing their oncologist, they were out from their cancers, they will put them on that. Sometimes women will go to their urologist because they have increased bladder infections because of the thinning tissues. They'll put them on some estrogen replacement to improve the health of the tissues. It is not something you use with intercourse. It's something that you use regularly, and it takes about 3 to 6 months to see an improvement in the health of the tissues. So for most women, you like use it every night for 2 weeks, give a little boost to the tissues, and then twice a week for maintenance. If you're doing great, if you stop it, you're going to get back to where you were, back it up to maybe once a week. Most of the women hate the applicators. Most of the estrogen replacements have been either Premature vaginal cream or Esterase vaginal cream. The applicators, most of my women don't want to use them. It's kind of a nuisance. They got to wash and clean out. So just, I tell them, draw it up to that quarter, squirt that on your finger. You're going to know exactly how much that is, and then rub that into the tissues. Then it's also not as messy. It doesn't fall out in a glump, you know, because you've rubbed that into the tissues, and you were also able to get it on the outside. Because what happens is at that vaginal opening, those tissues are thin. Women get tears. They're like paper cuts. It burns, it stings, it has to heal back. So with the creams, you're able to put that on there. That is usually my preference for women. There's a lot of products that have come out in the last year. This one, Imvexi, it is also an estrogen replacement, but it's in a vaginal suppository. There's the Vagifilm tabs that you insert on the end of a little applicator and inject that vaginally for absorption. So of course you do it at night so it like dissolves in the vaginal area. Some women will come in and they'll say, I heard there was a tablet. I don't want to do anything vaginally. I just want to swallow a pill, right? So Osphena is a pill, but the thing with Osphena is it is not an estrogen, but it works like that on the vaginal tissues, but it also has some side effects like hot flashes. And you also cannot take that if you are on oral estrogen, okay? So if someone is taking an oral estrogen and all their symptoms are good, but they're still having the vaginal dryness, you can easily add an estrogen cream because you're not getting like a double dose or anything. It's vaginal tissue, but this is not an option. So sometimes they'll think that they just want to take a pill because they're taking their estrogen pill, can't do them together. And then, you know, their data said it's not that often that women have hot flashes, and a lot of women did not stop it, but when I tell women that that's a potential side effect, they tend to like not want to go to that route. There's also something called Intra-Rosa. It is actually prasterone, so which is indicated for the treatment of moderate to severe pain with intercourse, and it is a non-estrogen treatment as well. It is a synthetic form of DHEA that does then convert into estrogen and androgens, and it is a vaginal insert as well. But I've had some really good results using this in women. The other thing I really want to mention is if you look over there, it says vaginal rejuvenation. Yeah. So again, there was just an article came out in our American College of OBGYN that said marketing before science. Yes, there have been risks reported, burn, scarring, and even pain afterwards, and given the potential for vaginal laser treatment to cause harm, we should hold off on performing or referring patients for this procedure until data from controlled trials become available. But I can tell you, I've had people who have had it done. I've had one lady who had such severe burns after one treatment that she had, it took a year for her tissues to get back. I've had some women who told me they thought it helped, and I've had some, and I did not recommend them for this, but they went and had it done because, again, they like didn't want to use any of this stuff and thought, I'll pay $3,000 and go 3 times, and all of my symptoms will go away. You know, one of them told me, she said, well, I feel like I'm better, but I think it's because I spent $3,000. You know, but, and our office has looked into it, and one of my patients said, you know, my urologist, you know, told me I should do it, and that all the gynecologists in town were just jealous because they didn't have the machine. It's like, really? Because our patients are complaining of the vaginal issues, and if it was going to work, and believe me, we have looked into it, and we have an aesthetic center, so we got all kinds of lasers down there, and we have been looking into it, but we didn't feel like it was there, and then this information just came out in the last few weeks that said It's not there. It was marketing before science. So be cautious with that. You might know someone who had it done who said that they felt better, but right now it's really not recommended. And I don't know, just the thought of lasering the vagina does not sound really pleasant. So I'm going to go on just to our last slide, because I think this is a really huge key. Is, as we were saying, those symptoms, they might go away. We got something. What's your choice is always going to be individual. You really just need to have that discussion with your physician. There's not one fix for everybody. It definitely has to be individualized. But the big things that we see is that we do have medical issues that increase after menopause. And some of that is due to the lack of estrogen. You know, some of it is due to the fact that, you know, just as we age, some of these come up. But especially for heart disease, and women need to know, it is the #1 killer of women, not just men. We have got to look at that. And one of the things is that we do develop a abnormal lipid profile. It affects our lipids abnormally after menopause. So what can we say? If you have a great lipid profile and it was tested before menopause, you need to make sure that it is followed, because you may not have the same. Because what happens is just the changes that go on with estrogen deficiency, you can have. It can cause your total cholesterol and your LDL to increase. There is, if you have a strong family history for heart disease, and this is not for my talk, but there's something called an advanced lipid profile. I personally was doing a test and found out that I had hereditary lipoprotein A. It does not really change with menopause, but it is one of the things that estrogen replacement can help some. But I think the biggest thing, what we see, like I said, your total cholesterol and your LDL levels, they can rise by up to 10 to 14%. Yeah. So, I mean, we just really, as women, need to know that, you know, heart disease is an issue for us, because it is also generally, heart attacks are usually more severe in women than in men. And in the first year after a heart attack, women are more than 50% more likely to die than men are. And in the first 6 years after a heart attack, women are almost twice as likely to have a second heart attack. So, you know, of course, if you have vascular disease, even though we know that your cholesterol profile may change after menopause, hormone replacement may not be for you, because if you have vascular issues, it also increases your risk for blood clots and strokes, which we want to avoid. So big thing is lifestyle changes, and we'll talk about that in a minute. Osteoporosis. A lot of women think, osteo, what do I need, a bone density? That doesn't sound like anything. You know, that can kill you. But I think when you look at these statistics, it really does open your eyes. It's something that women should have evaluated when they're menopausal, because we do all start to lose bone after menopause. So up to 30% of patients suffering a hip fracture will require long-term nursing care. Some 20% of women with a hip fracture will die in the subsequent year as an indirect result of the fracture, usually from a blood clot or such from immobility. In addition, once a person has experienced a spine fracture due to osteoporosis, he or she is at very high risk of suffering another such fracture in the next few years. And about 20% of postmenopausal women who experience a vertebral fracture will suffer a new vertebral fracture of bone in the following year. I think the biggest thing to take home about both of these issues that occur after menopause is that women aren't necessarily concerned about heart disease in them. They think it's a man's disease. It is their disease too. It is the #1 killer. And osteoporosis, if you suffer a fracture, can be life-threatening or debilitating. And when we look at women, they are more concerned about developing cancer. But truly, a woman's risk of developing a hip fracture due to osteoporosis is equal to her risk of breast, ovarian, and uterine cancer all combined. So the other thing we look at here, organ prolapse. Your stuff can fall out. You know, and why all those ligaments are estrogen sensitive, so they, you know, cause, you know, your stuff to stay where it's going to be. When you're estrogen, you have estrogen deficiency. Those cells get thin, atrophic, things start to drop, sag down. We stand up, our stuff wants to come out. And sometimes even women after a hysterectomy go, I had all my stuff out. So yeah, it can still affect you too. The vagina can fall through. They're like, oh, how is that? Hernia. You know, tissues get lax, it comes through, you start to feel like you're sitting on a tomato. Yeah, it can be the top of the vagina, it can be the bladder, it can be what's called a rectocele that's bulging. Any of those walls can bulge. So not that estrogen replacement is a reason to be on for any of these things, but these are things that we see when we have lack of estrogen in menopause that women have to look at. The sexual, we have to wait till the very end. Sexual dysfunction, frequently that is associated due to the vaginal dryness because of pain associated, and then weight gain. So I want to spend just a minute on this because being overweight, 2/3 of Americans are overweight, and this contributes to inflammation because fat cells secrete chemicals called interleukin-6 and C-reactive protein that promote inflammation. And that has been thought to be the cause of a lot of health issues. Heart disease at the root of a lot of health issues, inflammation. Heart disease, Alzheimer's, diabetes, you name it. And so one of the biggest things you can do as you're being menopausal is to make sure that you are doing the things that you personally can do as far as diet and exercise and trying to maintain a healthy weight, because those things in the long run are going to cause you to have actually less of these menopausal symptoms, but also less of these chronic health issues that develop after menopause. So being proactive is really important. You want to be seeing your primary care. You can talk to your gynecologist about it. C-reactive protein is a blood test. If you draw and see what your inflammation marker is, you want to get that in normal range. It is not something that you take an anti-inflammatory medication for. It is something that you increase your exercise, you eat properly, and those things help. And there was actually an article that came through on my email today talking about insulin resistance and how that increases hot flash symptoms, you know, and some of that is because of the fat cells, you know, inflammation, and that, so you can impact a lot of these health issues by what you do. Sometimes it's confusing. What do we do? I mean, like we got all these diets out there, and I think the biggest thing is that you want to think of it as, I'm doing this for my long-term health, not that I'm doing this for a short period of time to be on a diet and get where I want to be and then I'm going to do. So at this age, especially when you're in that menopausal range, and heck, if you can be proactive and start before, that's even better. But at any point, if you can say, I'm going to be proactive, I'm going to eat lean and clean, I'm going to like get some exercise every day. I mean, those are great things that you can do. Sometimes we don't even know what we're eating. I love this app called MyFitnessPal. I mean, you have it on your phone. Sometimes, I had somebody the other day, and I try to talk to my patients about their diet because it's confusing with all that information out there. What do I do? What's really healthy? And she was having a banana every morning. I'm like, okay, bananas are healthy, but it is 29 grams of carbs. So, I mean, you're pretty much halfway done, yeah. You know? So you just want to pay attention to that. And she goes, it's sugar? Yeah, I mean, it's natural sugar, but you know, if you look at your grams of sugar and your carbs, it's a lot. And a lot of people don't realize that. Some people think just because they're not putting spoonfuls of sugar in their coffee, it's okay to put a cup of honey just because it's natural. It's got a lot of sugar, you know. So again, so apps like that one especially can tell you, and sometimes women go, well, how many calories should I eat to lose weight? Well, how many calories are you eating now? Because if you don't know how many it's going to take for you to lose weight. Right. you know. So if you monitor yourself with one of these apps and you see how many grams of carbs and how many calories you're getting in a day, and you reduce those, it doesn't matter if you're menopausal and your metabolism slowed down. You will lose weight. And also becoming more active, it's going to help with your symptoms, but it also reduces inflammation. And it's going to be much easier to lose that weight if you're being active. So I think a key is being proactive about your health. Y'all are doing that because you're here at Pennington today, learning about a lot of this stuff. You know, there's a whole lot of all this screening debacle. I mean, you know, especially when women get to be menopausal, they're like, oh, do I still need to come? Do you have your parts? Yeah, but I thought that maybe after 70 I don't need anything. Are you healthy? Would you take care of something if I found it? Yeah. Okay, well, as you age, all your risk of everything go up. They don't go away. Oh, I thought that they went away. Nope, because I thought they went away because I had quit having my periods. Nope, they're there and they can cause a problem. So if you're healthy and you would take care of something, then you should still be seeing your gynecologist. Because as I say, I like this, we're more than a pap smear. Even if you meet the criteria to not necessarily do your pap smear, you probably need to discuss other health issues. You know, you're going to be needing your mammogram, you're going to need to be having your breast checked. Sometimes women think because they had their uterus out, they still have their ovaries, and they might not need a pap smear based on some of the new criteria if they meet that criteria from the reason they had their pap smear, which also makes it really confusing. You got your ovaries in there. I can't tell you how many women I find, several in a year, that something's in there and they didn't know. And they were really glad that they came in. So I think the key is ask your doc every year how often you need to see them. And if you're in good health and you would take care of something, you need to keep going. I tell women if you're in such poor health that you wouldn't take care of something, then you can quit coming. You know, so I'm going to let y'all ask any questions. Thank y'all so much for listening to me today, and there you go, ma'am.